Clinton. So here I have weekly quiz, and let's get at it. Let's get 5 questions done real quick. We're gonna start this timer because I don't want to have you guys here the whole day or myself. So we'll go through these questions real quick. As you can see, I haven't marked any of these questions, so I probably haven't done any of these questions. So it's the first time I'll see at least 90% of these questions, and if I have already seen them, I might not remember. So let's go on to question 1. Let's get this out of the way the quickest we can, and the idea is that we can actually see how quick we're doing this. So question number 1 says 72-year-old male. Okay, I go always to the question, what are they asking me? Why? Because in today's day and age, they're always trying to push you. We don't have time, and what you have to do first is get a gist of what are they trying to ask me about: diagnosis, management, etc. So which of the following is the most appropriate treatment? So options are acetaminophen, dantrolene, evaporative coolant, immersion in ice water. So in summary, the patient is hot. You can assume that off the bat. So let's see if what's the reason for the patient being hot. Depending on that, we'll have to decide management. So 72 years old, decreasing responsiveness after he spent the day at the zoo, outside temperature 38.9, has hypertension, uses hydrochlorothiazide and lisinopril. So it says spent the day at the zoo. Probably wasn't the heat, right? These animals in the zoo, probably not all of them will be roofed. So these animals need sunlight. So a physical exam temperature is 40.5. The patient is also hypotensive. So you can rule out option A. I could rule out probably option B almost for sure. And you have these 2 options: immersion in ice water and evaporative cooling. So the ice water, they'll say that the patient can get more burns because of the contact with the ice and all that. So probably this is gonna be the answer, I guess. So let's see what else it says. Hypotension, and these are let's see what else. Pulse rate is 117. Saturation is fine. Somnolent. Skin is flushed, warm, and dry. Tachycardia, okay. So I would go with evaporative coolant, and that's my final answer. That was the correct answer. Key point says treatment of non-exertional heat stroke includes evaporative coolant with water mist and fans, with or without ice packs to lower the core temperature to a safe temperature, usually 38.7 degrees Celsius. Okay, or 101.3 Fahrenheit. So it's basically reduced the temperature right very somewhat near to the cutoff of actually fever, because fever is 38.2, which is the same as 100.4 Fahrenheit. So very near to that. In older persons with non-exertional hyperthermia, ice water immersion is associated with increased mortality and should not be used. Okay, didn't know about that. So let's see the reason the ice immersion isn't an option. As I mentioned, I didn't like that one because of the burns, but let's see what's the exact reason. It may be necessary in young persons with exertional heat stroke when they remain severely symptomatic despite evaporative cooling, but it is not first line because it may be complicated by hyperthermia. So it could go the other way. In older persons with non-exertional hyperthermia, ice water immersion is associated with increased mortality and should not be used. Okay, so that's nice to know. Let's go on to the next question. Which of the following is the most appropriate management? So here you have begin omeprazole, discontinue fluticasone, salmeterol, begin fluticasone. So this one is GI problem, addressing a GI concern. This one is addressing the lungs. This one is also addressing the lungs. And this one is also addressing GI. So the first question is this a GI problem, option A and D, or is this a respiratory problem, option B and C? So let's rule this out. 54-year-old man is evaluated during follow-up visit for asthma. Okay, 5-year history, persistent asthma. He has had one exacerbation in the past year, which has been treated with glucocorticoids, so that's not much. Doesn't seem that bad controlled. No wheezing, but no intermittent non-productive cough. His asthma control test score is 24, indicating well-controlled asthma. He has adherence to his inhaler and demonstrate good inhaler technique. Describes symptoms of epigastric burning. So probably I'm ruling out B and C based on what I'm reading, which are the lung issues. If it's good, if it's not broken, don't touch it. So he describes symptomatic epigastric burn following meals. Yeah, so this is GI. He has no other gastrointestinal symptom. He does not smoke, exercises, medications already, and on physical, nothing special. So it's telling you this is a GI problem, and this patient is having symptomatic epigastralgia or GERD-like symptoms. So of course you'll do first lifestyle recommendations: eat small meals 5 times a day, bite-sized ideally. So, but you don't have to do the upper endoscopy unless the patient has risk factors for it, such as weight loss, such as other risk factors, or has already gone on trial of PPIs and hasn't worked. In this case, you'll try to do appropriate management, which is just try that, and if it resolves, all good. If not, go for the upper endoscopy. And that's the answer. So GERD is more common in patients with asthma than general population and may contribute to respiratory symptoms such as cough, wheezing, and dyspnea. Patients with respiratory symptoms and GERD should be treated with an empiric trial of proton pump inhibitor. So let's see why not perform upper endoscopy, the last option. So it's unnecessary and uncomplicated GERD without suspicion for malignancy, erosive esophagitis, or mechanical issues causing dysphagia, such as webs, rings, or strictures. So there's the Shatsky ring, there's the stricture. Okay. Patients whose reflux symptoms do not improve should be considered for further testing, as endoscopy and 24-hour esophageal pH monitor. Perfect. Next question. Let's go. Which of the following is the most appropriate treatment? So here you have N-acetylcysteine. So if this probably is in the context, well, I'm talking too much, but N-acetylcysteine is either you have acetaminophen toxicity, or you have a lot of secretions and you want to loosen them up, or what else? I think, did it work in G6PD deficiency? Why am I thinking about that? I don't know why I'm thinking about that crazy thing. I'm not sure if it was associated, but there's not many places you'll need the N-acetylcysteine. It's a great medication. I get it usually for when I'm congested, such as now, because it breaks the disulfide bonds in the secretions and makes secretions more fluid, so you can take them out. Pirfenidone. Okay, I've read about this a couple times. I've never given it in Costa Rica, where I come from. I've read it several times here in questions. Pirfenidone. Don't remember what that does right now. Third option is prednisone, N-acetylcysteine, and azathioprine. So I've never heard of this combo in any disease that I can recall right now, but we'll see what's going on. And last one is warfarin. Okay, now you're anticoagulating. Interesting. So 69-year-old man is evaluated for shortness of breath and a dry cough progressing over the past 7 months. So it's a chronic issue. Dry cough. Could this be chronic bronchitis? Maybe. Medical history is unremarkable. Does not take any medications. Physical exam. Respiratory rate 25. Oxygen saturation is 94%. Room air. It reveals Velcro-like crackles at the lung bases. Cardiac is normal. Labs, including serologic and connective tissue, is normal. PFTs reveals a restrictive pattern, and a DLCO 42% of predicted. So I don't remember the exact cutoff, but predicted is 100%. So 42% is very low. So this is the diffusing lung capacity of carbon monoxide. Carbon monoxide diffuses very easily through membranes, so that's why it's used as gold standard. If that thing isn't diffusing, yes, you have problems. So you have lung issues, and here you have the lung issues. This is telling you it indirectly, and also the what else? And saturation shouldn't be this room air. It's a little bit low. It should be how much? Here you got it, 95 or above. So chest radiograph reveals reticular infiltrates in the lower lung zones, high res CT scan consistent with usual interstitial pneumonia pattern. So the answer isn't gonna be N-acetylcysteine. So now basically the question is, do you know what to give interstitial pneumonia pattern? That's it. It's like all that was unnecessary. I should have scanned this quicker. You're not gonna give this one, you're not gonna give this one, and this one you're not gonna, it's probably gonna be this one, although I have never read N-acetylcysteine in other contexts, so I'm doing this through rule out. Pirfenidone, it doesn't sound like it, but N-acetylcysteine doesn't sound like it unless there's a new study that showed this and that. It definitely isn't N-acetylcysteine alone. It definitely is not option D. It could be C or B. Does C make sense? Sort of, but there's two immunosuppressives off the bat. A little too aggressive. This one and this one. So that's why I wouldn't go with that one. I'm going with this one, and that's the answer. Okay. Therapy with pirfenidone or nintedanib decreases the rate and progression of idiopathic pulmonary fibrosis, but is not curative. In patients with idiopathic pulmonary fibrosis, lung transplant is a life-prolonging therapy for those without comorbidities that may otherwise limit life expectancy. Let's just talk a little bit more about these two medications. 2014 FDA approved two medications, pirfenidone, an anti-fibrotic agent, and nintedanib, a tyrosine kinase inhibitor for use in patients with idiopathic pulmonary fibrosis. Okay, so those are your two medications. I'm gonna mark this one just so we remember it. And what else am I gonna see? Mitigating rate, okay, it improved it a little bit. Okay, decline by mitigating the rate of FVC, forced vital capacity, declined by approximately 50% over the course of 1 year. That's incredible, right? Okay, that's very good. So yeah, it has side effects, nausea, anorexia, photosensitivity, and diarrhea for nintedanib. Although these medications delay IPF progression, they are not curative. Referral to a pulmonologist or interstitial lung disease center is appropriate. Yeah, you shouldn't try to manage these patients alone. It's a chronic thing that will require several evaluations, so refer these patients earlier than later. And that's it. Okay, that's it. Let's go on to the next one. Question 4. Which of the following is the most appropriate additional treatment? So options are nocturnal non-invasive BiPAP, bi-level positive airway pressure ventilation. Another one is roflumilast, supplemental oxygen, and nothing else. So first question is, do we have to do something or not? And if we have to do something, which of these? So inhaler technique is reviewed. Okay, immunizations up to date. pH is normal. PCO2 is within the normal range. PO2 is a little decreased, but not in the range of respiratory insufficiency, which is a ABG diagnosis. So let's see what else we have for information. Oxygen saturation 96%, breathing room air. So this patient doesn't need oxygen. There's no criteria for oxygen unless it's saying that the patient desaturates upon walking or something. So this one is out of the picture, this one is out, and we have these two options. 5 years ago, for COPD exacerbation, evaluated for discharge, he required bi-level for 1 day because of acute hypercapnic and hypoxic respiratory failure, treated with prednisone and levofloxacin. This is his second hospitalization for a COPD exacerbation in the past 6 months, and fourth course of prednisone for his COPD in that time. So this patient has decompensated several times, is doing quite well right now, but has decompensated several times in the past year. He had a baseline function limited. So this is gonna be okay. Once again, roflumilast. I don't remember 100% what it was. I think it's one of those, I guess, antibodies that might help in, I don't know, I guess COPD in this case. So why do you want to give this patient BiPAP at night if their oxygen levels are fine? It's not saying you don't have the stop bang criteria here, telling you about obstructive sleep apnea. It's not telling you anything about that. So that's not the specific problem. This oxygen, no. This is gonna be this one, just ruling out the other options. So roflumilast, a selective phosphodiester 4 inhibitor, can reduce symptoms and exacerbations in patients with severe COPD who have a chronic bronchitis phenotype or frequent exacerbations. Okay, so it's a PDE4 inhibitor. What I don't like about these questions is it gives you the answer, but it doesn't explain you always the why. Let's see if it explains the why. COPD with a gold group E severity based on his symptoms burden and exacerbations. He's already receiving inhaled therapy with long-acting beta-2, long-acting, so LAMA, and inhaled glucocorticoid. Roflumilast, a selective PDE4, can reduce symptoms and exacerbations with severe COPD who have chronic bronchitis phenotype. Okay, and what else? I want explain to me why, please. Given this patient's scenario, he would likely benefit from the addition of roflumilast. Okay, but why? Why do PDE4 inhibitors improve this patient's COPD? That's my question. I don't know, but I know the answer, right? Azithromycin, a macrolide, you can use that with the exacerbations, because that's the idea with these patients with not the simple exacerbation, but complex exacerbation. Or exacerbation in COPD. You can definitely have to consider antibiotics. Okay. And what does it say about BiPAP? It can be prescribed or non-invasive in NIPPV. If you're obstructive sleep apnea or chronic hypercapnia respiratory failure, which the patient does not have. Okay, that's it. Let's go on to the last question for now. Which of the following is the most likely diagnosis? This thing looks like mosaic pattern. So this is like a mosaic pattern. So it's telling you there's definitely lung disease. When you have the infectious one is usually tree in bud. So at least for a test question, it's not gonna look exactly like this. I believe this looks more like, at least this image. Let's try to zoom in on it. It looks more like mosaic. I think it looks a little more like mosaic, but I could be wrong. Non-specific and respiratory bronchiolitis associated. Okay, let's see what are the options. What else we have? 66-year-old male, a gradually progressive shortness of breath, dry cough for 6 months, has been a smoker for stopped 10 years ago. Physical shows a respiratory rate a little bit elevated, 22. Saturation mildly decreased at 93%. Breathing room air has the Velcro crackles. Nothing. Clubbing is present, but all of these can produce clubbing. Spirometry shows an FVC of 55% predicted. So when you see the gold classification, you can, if it's COPD, but if you see right here that FEV1 over FVC shows it's 0.9, so this isn't obstructive, this is restrictive. The FVC is reduced, and the LCO is also reduced. high res shows you this. So basically this is gonna get at to, do you know what is the most common cause of the interstitial lung disease in this smoker, 66-year-old smoker, ex-smoker male, with a possibly mosaic pattern? So idiopathic, I think idiopathic pulmonary fibrosis, they wouldn't give you the information that he was a smoker. Non-specific interstitial pneumonia, no, because this is bilateral. This doesn't look like pneumonia. Cryptogenic organizing pneumonia, bronchiolitis, respiratory bronchiolitis. This was called Bono in the past. Was it Bono? Bronchiolitis, no, something. Why pneumonia? Doesn't look like pneumonia. It's saying, doesn't even saying if he has fever or not. Clinical examination saying he has a productive cough or anything like that. So I would rule this one and this one out. And this one, he's a smoker, so the test wouldn't give you smoking for this one. It may be probably this one. And it's not that one. It's idiopathic pulmonary fibrosis. So idiopathic pulmonary fibrosis presents in patients between 50 and 70, greater than 6-month duration, dry cough and dyspnea on exertion, the Velcro-like crackles, clubbing 50%, and honeycomb changes on high-resolution CT scan. Let's look at the characteristics of the CT. The best diagnostic test is high-res CT. Basically, this is a CT without contrast that has a finer slicing technique, so you can see more specifically what you're looking for. But nowadays, CT scanners are pretty good, so you could see it in almost any non-contrast CT. But of course, if you want to do a dedicated one, okay. So bilateral peripheral and basal, predominant septal thickening with honeycomb changes. Okay. Involving a thoracic, radiologist, pathologist, and pulmonologist. So it's multidisciplinary discussion, and possibly you don't need the lung biopsy. So they have moved a little bit away from the lung biopsy because you can determine this clinically in most cases. Cryptogenic organizing pneumonia, cough, fever, malaise, as I mentioned, high resolution CT, infectious pneumonia. Okay, findings can include peripheral nodules and nodules along bronchosvascular bundle. Non-specific interstitial pneumonia, what does it show? Is the most common. What's this DPLD, diffuse parenchymal lung disease associated with autoimmune disorders, but it can occasionally be idiopathic. Okay, and affects younger population than IPF. High-res CT demonstrate bilateral lower lobe reticular changes and absence of honeycombing, but can demonstrate areas of ground glass. Okay, so that's nice. I'm gonna review all this thing. And respiratory bronchiolitis is the histopathologic diagnosis associated with high-res CT finding of centrilobular micronodular disease in current smokers. Okay, so basically this is a nice one. I might talk a little bit more about this in another one, but that's it for now. Okay, see you in the next video, and we'll wrap it up right there. So see you later.